My name is Caroline Nguyen. I'm an assistant professor of clinical medicine and OB at the USC Keck School of Medicine. I'm an endocrinologist. My focus is on thyroid and in pregnancy. So I take care of a lot of patients with thyroid conditions in their pregnancy, ranging from hypothyroidism to hyperthyroidism, and then including thyroid cancer as well. And I'm in very focused in that area, and also involved in kind of like the teaching and stuff that we do at USC. So thank you for having me participate in the ThyCa meeting. I've been at a few ThyCa meetings in the past, and it's always been great to participate and get to meet the members of this group. You guys do such a lot of great work for the community. So hopefully you'll find this helpful. Dr. Desai kind of recommended that, a talk on thyroid cancer in pregnancy. And so my part of the talk is going to be focused more on the preconception, a little bit on the pregnancy, and then some on the postpartum considerations. And then Dr. Desai is going to be talking more about thyroid cancer within the pregnancy itself. I think that the audience can't talk and participate, but there's a chat option, right? So you can
absolutely
ask questions if anything comes up, and perhaps we'll just go through the slides pretty quickly, and then we'll kind of filter through those questions and hopefully try to address it with the time that we have. Does that sound good with you, Dr. Desai?
Yes, sure.
Yeah? Okay, perfect.
Thank you.
Okay, so we'll go ahead and
that was a great intro.
All right, so we'll get started. Let me go ahead and advance. So for the preconception considerations, so I kind of focus this a little bit like a case-based to kind of do a little bit of guidance in this. So the question is, I have thyroid cancer that was treated 3 years ago. I received radioactive iodine and I'm doing well. I have had no evidence of recurrence on ultrasound and my tumor markers are undetectable. Is it okay for me to get pregnant? And the answer is yes, it is okay to get pregnant at this point. And so we can kind of talk a little bit about some of the issues around this. So the recommendation by the American Thyroid Association is that anyone who's received radioactive iodine wait for a period of at least 6 months prior to trying to become pregnant. And so the patient in the scenario is 3 years, way outside of this window. So there's no concern there about becoming pregnant. Am I at risk for worsening of my thyroid cancer if I get pregnant? So this is a little bit more of a nuanced answer. The pregnancy does not pose a risk for tumor recurrence in patients without evidence of structural or biochemical disease prior to pregnancy. So what that means is if you were diagnosed before, you got your thyroid cancer treated, resected, you're doing very well, your tumor markers are undetectable or very low, and you don't have any structural disease, then there should not be any we haven't had evidence to show any significant concern that pregnancy is going to be an issue. However, if you have some structural or biochemical disease, there has been some data to suggest that pregnancy may represent a stimulus to thyroid cancer growth in these scenarios. So for this question, it really warrants a close discussion with your physician to look at where you are in regards to your thyroid cancer to kind of give you an estimation of, or a prognostic kind of discussion about how pregnancy could affect that. So are women with thyroid cancer at risk for worse pregnancy outcomes? So this paper was done, published in Thyroid in 2018, and it looked at over 7,000 women with thyroid cancer and over 2 million women without thyroid cancer, and looked at their offspring, and they were followed for 80 months. And the conclusion of the paper was that women with a history of thyroid cancer had similar pregnancy outcomes, and the offspring had similar growth when compared to those with no thyroid cancer history. In addition, risk of like cesarean section, preterm birth, low birth weight, large for gestational age, preeclampsia, or placental abruption, some of these other complications that can occur were not different between the two groups. Some pre-pregnancy considerations to keep in mind. So a patient says, I just found out I am pregnant. Does my dose of levothyroxine need to be adjusted? And the answer is yes. In terms of dose adjustment, so in the setting of pregnancy, thyroid hormone requirements increase by 25 to 50% in women without thyroid conditions, right? So women who have had thyroid surgery and who are now taking levothyroxine typically require an increase in levothyroxine dose by 25 to 50% during pregnancy to meet this increased demand. So it's not uncommon for your physician to recommend like a 25% increase kind of initially right when you find out if you're pregnant, to kind of try to continue to keep your levels where they were before. So again, kind of the goal, right? So what's the goal of your TSH? So this is from the American Thyroid Association guidelines. So pregnant women with thyroid cancer should be managed at the same TSH goal as determined pre-conception. So the TSH should be monitored approximately every 4 weeks until 16 to 20 weeks of gestation, and then at least once between the 26 and 32 weeks of gestation. So what that means is, so if your physician felt like you needed to have your TSH suppressed prior to pregnancy, then they may recommend that you continue the suppression in your pregnancy as well, and they would alter the dose to meet that goal for your TSH. And it has been shown it's been felt to be safe to do that as needed for the treatment of the cancer. And then monitoring, that guideline kind of already discussed, at least in terms of the laboratory monitoring for just the thyroid hormone replacement. Historically, if you've had thyroid cancer and you have no structural or biochemical disease left, then you actually don't need any sort of dedicated monitoring during the pregnancy. But your thyroid hormones levels should be checked periodically, as we discussed previously. If you have structural or biochemical disease, then the recommendation is to monitor with a thyroid ultrasound periodically in pregnancy, and also your tumor markers as well. And usually, I would say most people do like the tumor marker checks like every trimester approximately, and then the ultrasounds kind of as indicated based on your history. And so now going to some postpartum considerations, the levothyroxine dose adjustment. So once you're postpartum, you're going to need to reduce your levothyroxine dose again to kind of meet your pre-pregnancy dose. And that can happen right once you deliver. And then we typically recommend that your TSH be checked about 6 weeks after delivery to assess that dose change. Is it okay to breastfeed if you've had thyroid cancer? It's a minimal amount of maternal thyroid hormone is present in the breast milk. It's a very small amount, so it's overall considered to be very safe to breastfeed on thyroid hormone supplement. In terms of radioactive iodine, however, that does concentrate in your breast milk. So radioactive iodine is contraindicated in any woman who's breastfeeding. And if it were needed for a particular study or some study, if I-123 were needed, then the breast milk should be discarded for several days. And if a patient who is breastfeeding needs treatment with the radioactive iodine, recommendation is to hold for breastfeeding for 6 weeks prior, ideally, to reduce radiation exposure to the breast and risk of milk leakage and contamination with radioactive iodine. And that is my last official slide. Go ahead and stop sharing. And Veronica, do you want to go ahead and then go to Dr. Desai's talk and then open it up for questions at the end?
Absolutely. We are trying to get her slides together so we can get them shared on the screen.
Let me see if I could just screen share it from here. I'm going to try this first. Okay. Can you guys see my screen?
We can.
Okay, awesome. Hi, everyone. I'm Kaniksha Desai. I am one of the endocrinologists at Stanford University School of Medicine, and this is my third time coming to ThyCa. I'm super excited to be here. This talk that we started on is to address thyroid cancer during pregnancy. My specific half is going to be what happens for a newly diagnosed patient who is pregnant while they get diagnosed. So we focused a lot in the first half about preconception for patients who are thyroid cancer survivors, as well as, during pregnancy monitoring if you've already had thyroid cancer. But what happens if you get diagnosed with thyroid cancer during pregnancy? Okay, so quickly outline for my talk. We'll talk about the symptoms of new thyroid cancer during pregnancy, how to diagnose and treat it, and then as well as the prognosis. So how common is thyroid cancer in pregnancy? We can't talk about thyroid cancer without talking about nodules. So thyroid nodules, as everyone here knows, they're pretty common. So the prevalence of thyroid nodules in pregnancy are reported to vary between 3% and 20 to 30%. So as with pregnancy, there's a growth with the fetus, there's a growth of a lot of the organs in the body. So the thyroid gland can grow up to 10% when you are pregnant. So this can result, not necessarily, but can result in the growth of previous nodules as well as some new nodules during pregnancy. It's actually thyroid cancer is the second most common cancer during pregnancy. But thankfully, the prevalence is pretty low with only 14.4 incidents per 100,000 births. So it's still pretty rare. It does have a slightly increased risk with age and the number of pregnancies that you have. So what are the symptoms that someone might have for thyroid cancer during pregnancy? As your thyroid gland grows, you can actually get a goiter. So that just means swelling of the thyroid gland. You can get a mass or lump on one particular side of your thyroid gland. Depending if that's on the left side or how large it is, you can get problems with swallowing or a hoarse voice. But most of them are actually incidental findings. Ideally, we would not like to have imaging during pregnancy, but sometimes it's required for other reasons, and you can actually find the nodules that way as well. So how do you diagnose thyroid cancer during pregnancy? When you go in to see your obstetrician, they're going to feel your neck, so physical exam of the neck. If you have any risk factors, so the risk factors are any family history of thyroid cancer or childhood exposure to your neck area. If your OBGYN or endocrinologist that you're following with feels something on the exam, they might order lab testing with TSH for function. And then the main way to diagnose thyroid cancer during pregnancy is through the ultrasound of the neck. So this includes your thyroid gland as well as lymph nodes looking for thyroid nodules or abnormal findings. We use the same criteria that's used for non-pregnant women, which is ThyRAD's radiology criteria or the American Thyroid Association nodule criteria to determine an FNA biopsy. So biopsy is how we get to the diagnosis. Biopsy is safe during pregnancy, as is the ultrasound of the neck that uses the same imaging modality that the ultrasound that the fetus gets. So it's safe during pregnancy. The cytology that's on FNA biopsy is similar to the cytology for non-pregnant patients. So that's also really helps us in diagnosing this during pregnancy. And we still have the same typical cytology results. So what do my biopsy results mean? The monitoring and the follow-up is slightly different for pregnant women versus if you were not pregnant. So for benign thyroid nodules, if we find a nodule on ultrasound, it's the same as if you were not pregnant. We just monitor with a follow-up ultrasound after delivery, especially if it's later on during pregnancy. The difference really here is if they find these atypical cells. Normally, if you're not pregnant, we send for molecular marker testing to determine whether we need to have any sort of treatment. The Afirma, the ThyroSeq molecular markers have not been tested in pregnancy. So this is not routinely used. It's not used during pregnancy. So what we do if you have atypical cells on your biopsy results, we would monitor with the follow-up ultrasound usually after delivery. If it's a very suspicious appearing nodule, we might consider repeating the ultrasound later on during pregnancy, but majority of the time we just repeat the ultrasound after the pregnancy. If there's a question whether it's suspicious for thyroid cancer, the risk of that suspicious for thyroid cancer is about 60 to 75%. So this is not a diagnosis of thyroid cancer. Since we're not clear that it's a diagnosis and it's only a 60 to 75% risk, a lot of times we'll also monitor this with serial ultrasounds. However, this one we would monitor during pregnancy as well as post-delivery. And then if you do get diagnosed with papillary thyroid cancer on biopsy results, we have an option depending on the size and the location of the cancer, as well as other features, whether we want to do surgery during pregnancy or monitor during pregnancy and do surgery after delivery. So what is the treatment of thyroid cancer diagnosed during pregnancy? Active surveillance. So a lot of you might have heard of active surveillance, which is just another term for monitoring. We monitor with ultrasounds to see if there's any growth. We can do surgery to remove the cancer. So we'll talk about some indications next about whether we would do surgery versus monitoring. We can do thyroid hormone replacement. So this happens especially if your TSH is high. So we got that blood test to see if your TSH is high. But generally, if we also diagnose you with thyroid cancer during pregnancy, we want to keep your TSH in the bottom half of the normal range. So your endocrinologist or your OBGYN may recommend some thyroid hormone replacement. Thyroid hormone replacement is safe during pregnancy, but this is to ensure that all outcomes are best for you as well as the baby. And then, as we previously stated, radioactive iodine is contraindicated during pregnancy and for breastfeeding women. So that we do not use for treatment at all for thyroid cancer for pregnant patients. So if we chose monitoring, what would the monitoring be? So thyroid ultrasound each trimester, especially if this is diagnosed in the first trimester. We have thyroid suppression. We call it suppression therapy, but basically if your TSH is higher than 2, we would consider giving you levothyroxine. Some endocrinologists use 1 as the cutoff, but if it's on the higher end of normal, and definitely if it's above normal, we would recommend levothyroxine replacement therapy. And then we would do your surgery, your initial treatment post-delivery. Generally, we wait a minimum of 6 weeks post-delivery, but the timing would be discussed between your surgeon and your thyroid surgeon, your endocrinologist, and your OBGYN. So who needs surgery, like absolutely needs surgery during pregnancy? There are certain cases that we would consider doing surgery during pregnancy. If you have abnormal lymph nodes, which suggests that the thyroid cancer has spread outside the thyroid bed, which is a slightly higher staging and risk. If you have any sort of aggressive variants of thyroid cancer, which include tall cell variant, sclerosing variant, these are very difficult to diagnose with FNA biopsies. So most of the time we actually don't know until we remove the actual thyroid cancer. Again, this is also very, very, very rare, but if you have distant metastatic disease to your lungs or elsewhere, we may consider doing surgery during pregnancy. Medullary and anaplastic thyroid cancer are even rarer than regular thyroid cancer during pregnancy. But unfortunately, we don't have a lot of long-term data on medullary thyroid cancer during pregnancy. So a lot of times we do the surgery during pregnancy. And then anaplastic thyroid cancer, as I'm sure most of you know, is a very aggressive form of thyroid cancer. So waiting for the remainder of pregnancy to be completed and delivery will cause this disease to progress. So we recommend treatment during pregnancy for those patients. If we choose monitoring, if your thyroid cancer nodule, which has been biopsy-proven cancer, is enlarging over a 50% growth in volume or a 20% increase in diameter in 2 out of the 3 dimensions, generally we would recommend considering surgical removal because the cancer is growing during pregnancy. This generally is done during the 2nd trimester. So the ideal time is to not do it in the first 12 weeks because of the high rate of miscarriage. And if you do it too close to the delivery date with anesthesia and the stress of surgery, there's a higher risk of premature delivery. So the 2nd trimester is the ideal time to do surgery for treatment. So what are the risks of surgery during pregnancy? We have to consider two individuals here. What are the maternal risks and what are the fetal risks? So as far as the fetal risk, the risk of miscarriage, which occurs most likely in the first 12 weeks. So that's why we wait to the second trimester, and then the risk of premature delivery if you're waiting to the third trimester. The other consideration for fetal risk is hypothyroidism following surgery. Then for the maternal risk, there's surgical complications, which are two categories, which is non-endocrine related, which is bleeding, infection, anything related to anesthesia, which would be similar to all surgeries during pregnancy, and endocrine related, which is maternal low calcium from parathyroid hormone going low, or recurrent laryngeal nerve injury, which is voice damage from the actual surgery. Of course, as with non-pregnant patients, higher surgeon volume does have a slightly lower rate of complications. So if you were to need surgery during pregnancy, we'd recommend that you go to a tertiary care center, which does high rates of surgery for specifically the thyroid gland. And I just wanted to finish up at the end with prognosis. So it appears we do have limited data. We do have some data, but it's a little bit limited about pregnancy and thyroid cancer because of the rarity of the condition. But it appears that most of the time there's no significant impact on the overall long-term prognosis of the thyroid cancer, whether or not you wait for surgery during pregnancy or surgery after delivery. There is some conflicting data about reoccurrence rates with, I think, one or two studies that have shown a slightly higher reoccurrence rate if you're treated during diagnosed and treated during pregnancy versus after pregnancy. The overall risk of progression during pregnancy is pretty low, which is why we recommend the monitoring, especially in smaller cancers under 1 centimeter. And most of them will be stage 1, 99% of them will be stage 1 at the time of diagnosis. So what do I need to remember from this talk? The thyroid gland grows during pregnancy, as does other organs, and nodules may form. To diagnose thyroid cancer during pregnancy, the diagnosis requires neck ultrasound and FNA biopsy, which are both safe during pregnancy. For a small cancer that's located in the thyroid gland, serial ultrasounds for each trimester may be recommended. If you need surgery, the recommended timing of surgery is in the second trimester to prevent miscarriage as well as premature delivery. Radioactive iodine is contraindicated in pregnant patients and breastfeeding patients, and the overall prognosis is not significantly impacted by diagnosis during pregnancy. Okay, that was my section of the talk.
All right. Well, we have a lot of questions in the chat, so Q&A, and so we have a few from Krishna, Celeste, Amy, and Stephanie. So why don't we start at the top? We have about 9 open questions, and I think we have time for most of them. So when monitoring TSH during pregnancy, how often would blood tests and ultrasounds, how often would you need blood tests and ultrasounds of the neck?
Do you want to get that, Carolyn, or do you want me to? I don't know how you want to split the questions.
Yeah, I think we both kind of touched upon it, like in the talks, and it's not clearly defined, you know, like in terms of strict kind of recommendations, but in general, I would say for anyone with hypothyroidism, we're generally checking TSH levels every month in the early part of pregnancy until about mid-gestation. And then depending if you're relatively stable, then you could, you know, extend that period of the frequency of testing. But that's up to you and your physician. And then usually at least one time after, like in that third trimester period, right? So between 26 to 32 weeks, at least one time there too. So it's definitely a little bit more frequent in the beginning because that's when all the hormonal changes of pregnancy really occur. The dose may need to be adjusted more frequently, and then it tends to stabilize as you move farther out. But with patients with thyroid cancer, I think most physicians are going to keep a pretty close eye kind of throughout the whole pregnancy for you. In terms of ultrasounds, you know, if you have no kind of residual disease, low risk disease going into your pregnancy, then not really necessary to do surveillance ultrasounds kind of just to do them in the pregnancy. But if, you know, things came up on exam or your tumor markers changed, those would be kind of indicators to potentially maybe get a thyroid ultrasound. And then I'll leave it to Dr. Desai to talk about patients that have active cancer or new cancer. Yeah.
So new cancer during pregnancy, generally, if you're diagnosed in the first trimester, we would recommend a follow-up ultrasound at the second trimester, as well as early third trimester to monitor for growth. If it is growing, then obviously we would change the treatment plan. As far as your TSH, at the time of diagnosis, we would recommend a TSH. If it's on the bottom half of the normal range, then generally we wouldn't recommend checking it. You can check it, but generally it's not going to change that significantly. If it's on the higher end and we start thyroid hormone replacement therapy, then we would need more monitoring and we would go to like the monthly check-in to see how the levels are doing.
Awesome. Thank you both so much. We have another question that says, what would you suggest the course of treatment be for someone with no thyroid, lymph node nodules, and metastatic disease to the lungs?
Well, sorry, the first part of the question again, what would the course of...
What would you suggest the course of treatment be for someone with no thyroid, lymph node nodules, and metastatic disease to the lungs?
In a pregnancy or pre-pregnancy? Where are we in that?
Well, this is from Shelby. So I don't know what she means by this, or what they mean by it.
I would take it, we're going to apply it to pregnancy, right?
Yes.
So somebody interested in pregnancy who has maybe some, or who has known residual disease, metastatic disease. So, you know, from the limited data we do have, there is that potential that that residual disease can get worse in pregnancy. So I think that has to be like a discussion that the patient has with their physician. Because depending on, you know, are these tiny little micronodules like really small, or is this more involved disease of the lung? And this is where it gets pretty nuanced and does need to be taken pretty seriously about, you know, like if that were to progress, like what that might mean, right, for the patient and the pregnancy. Kaniksha, do you have anything you want to add for that?
No, I think that you can't, it depends on how controlled your thyroid cancer is, like all these lung nodules decreased in size after your initial treatment, and are they growing or not growing, whether it's going to change during pregnancy.
Mm-hmm. Perfect. And they did respond and said pre-pregnancy. So thank you so much. So the next question is papillary thyroid cancer hereditary and can it be passed to an offspring? Is there genetic testing to determine if your offspring could have papillary thyroid cancer from your family history?
So during pregnancy, it's not going to be passed on to your offspring. So in that sense, no. There are certain mutations that do run in families. So medullary thyroid cancer in itself is very mutation-based and can run in families. And we do recommend screening for family members, depending on the type of mutation and the age of diagnosis of the initial patient. But as far as papillary thyroid cancer, yes, there are some genetic mutations. We don't routinely recommend checking family members at this time. That recommendation may change in the future, but we don't routinely recommend checking family members. It's just a slightly higher risk. And if your family members has nodules, then we would recommend, you know, evaluating those, but preemptively checking, we don't recommend. And Carolyn, did you have anything else to add?
No, yeah, I think that covers it.
All right. Celeste would be curious to hear your thoughts on the safety and efficacy of pursuing IVF following 2 rounds of radioactive iodine treatment for an aggressive papillary thyroid cancer.
Mm-hmm. So, you know, it's not necessarily like the IVF component of it, I don't think adds, as far as we know at this point, you know, there's not a lot of data out there looking at maybe ART, IVF, and its potential influence on thyroid cancer. Very limited. Maybe an increased association of cancer, but I would say there's just not enough really to say definitively. So I would look at it more of just like pursuing a pregnancy after 2 radioactive iodine treatments. And we don't see that as a contraindication. I think as long as you're waiting the appropriate period of time after the radioactive iodine, there's no reason that a patient couldn't pursue IVF or ART to become pregnant. And then everything that we talked about that would apply for aggressive papillary thyroid cancer would still apply in this scenario, right? So if you still have a lot of residual disease, or that has to be taken into consideration. But the fact of it being like an IVF in itself, not necessarily should not be an issue and not a contraindication. Now, the process of getting some of the hormone therapies that you would receive, like ovarian stimulation, in that process, sometimes the thyroid hormone levels can become altered after those procedures periodically. So generally, we would do a consultation and just say, make sure that your thyroid levels are back to normal kind of before you go in through the whole embryo implantation process. And then to check your levels after that ovarian stimulation process, because it could be a little bit different and altered from the treatments for that part of the ART. But then afterwards, as long as you make sure your levels are normal going into the pregnancy itself, the approach is very similar.
Do you want to add anything, Dr. Desai? No?
I think she
Okay,
got all of it.
perfect. Thank you so much. All right. So are there any studies done on the effects of synthetic levothyroxine on the developing fetus versus natural T4 and T3?
Do you want to get that and then I can expand, or?
Sure. I mean, so in general, because I think there was a couple questions on here about the use of T3 or liothyronine, desiccated thyroid hormones. In pregnancy, the standard of care is levothyroxine or T4 alone. The reason for this is that the T3 does not effectively cross the fetal blood-brain barrier. So when a mom is taking T4 and T3, there is a concern that baby is not getting adequate thyroid hormone, and baby is completely relying on mom for thyroid hormone in the early part of pregnancy, and possibly even throughout the pregnancy too, we detect maternal thyroid hormone in the fetus. So that is the reason why we do not recommend T3 or combinations of T3 in pregnancy. Don't know if that answers the question enough.
So the only thing that I was going to add is that, if you are trying IVF and doing other pre-pregnancy counseling, then we would take you off of your natural desiccated thyroid hormone, switch you over to levothyroxine, or stop the T3 if you're getting levothyroxine and Cytomel, and then restart it after your delivery. If you just happen to get pregnant and it was surprised or you weren't planning, then we would stop at the time when your positive pregnancy test was and then restart after delivery. So it's fine to restart it after the delivery. It's just really during the pregnancy part that's the biggest issue.
All right, thank you so much. Following up on that question, very similarly with the levothyroxine question, have you noticed a difference in the amount of levothyroxine that is needed for mothers carrying either a male or a female baby? One participant says she's carrying a boy and had to increase her thyroid medication significantly more than when she was pregnant with her daughter.
I don't know that we actually have research data on this. I think every pregnancy is actually different. So the amount of thyroid hormone that you would need is not necessarily gender specific or multiple specific. It's more where you are in your life journey. You're a little bit older, presumably for your second pregnancy, there can be other environmental and circumstantial differences. You could have been taking brand name versus generic. I don't think that one baby necessarily takes more than another. Again, every pregnancy is different, so you can't say that in my first pregnancy, I increased it by this much, so now I'm going to need it for this much for my second pregnancy. I don't know, does Carolyn have anything else?
I'm not aware of any studies. Yeah, and I agree, like, so either different timing, different place, but also if you're like on a different manufacturer, I think that was a really good point that you brought up, because that is very common, like that a manufacturer of your thyroid hormone might have changed, and that could also alter the change that is required in your pregnancy.
Great, thank you so much. We have a question here from Stephanie, basically saying she's 27, had a total thyroidectomy, no need for radioactive iodine therapy, just HRT. Her blood work and ultrasounds are great so far, and she wishes to have kids one day, but wonders what are the chances compared to a normal quote unquote woman, and who should she call first, her OBGYN or endocrinologist?
Mm-hmm.
So there is some conflicting data. Well, you never got any radioactive iodine, right? Yeah, so I think your chances of pregnancy are the same as a non-pregnant or a non-normal, so-called normal person. The main thing is to make sure that you're not hypothyroid at the time of pregnancy or when you're trying to conceive. So your TSH obviously needs to be under 2, ideally. If you were hypothyroid, then there could be an increased risk of miscarriage or fertility issues. I don't know if Carolyn has anything else to say about that or timing wise. I think usually if you're an excellent response to treatment, you can go ahead and proceed with pregnancy.
Mm-hmm. Yeah, I agree.
Well, we have a different question here that's about the father. So what is the optimal waiting time to seek pregnancy post RAI if done on the father?
3 months. Oh, sorry.
Go ahead.
Okay, so sperm regenerates itself in 3 months, so at least a minimum of 3 months as far as the sperm damage is. Some nuclear medicine people use the same as male versus female, which is a 6 to 12 month period, but it's a minimum of the 3 months. Sorry, Carolyn, if you had a different opinion or recommend waiting longer.
No,
So,
go
ahead.
No, go ahead.
So there's another follow-up about males in the effective pregnancy. Someone asking to discuss the issues with males of prior papillary thyroid cancer and 2 RAI treatments 10 years ago, and if there is any effect on pregnancy.
In someone who got RAI 10 years ago?
Mm-hmm. Two RAI treatments and a prior papillary thyroid cancer diagnosis.
I think kind of what Dr. Desai already mentioned, it really seems to be affecting kind of more acutely post-treatment. Thus far, I'm not familiar with any data of long-term effects at all on offspring and pregnancy. Yeah.
All right. We are getting lots of questions in. So the next question is, can you please discuss, does RAI affect your eggs? One doctor shared that the patient would receive have menopause early due to RAI treatment by at least 1 year, and they're wondering if RAI is also genetically mutated or damaged the eggs while also being hypothyroid due to their high TSH levels for disease suppression.
Okay, so there's a lot of questions in that. So I'm
there are, yes.
Does RAI affect oocytes, right? So initially, yes. So that's the recommendation for waiting the 6 months. And that is because there is a concern that maybe the radioactive iodine is affecting the ovaries and the oocytes. Outside of that, it's felt to be safe for the baby and in terms of effects of the radiation. Now, in terms of oocyte production. So, and this has been done with studies looking at ovarian reserve using a marker of anti-Mullerian hormone, which is kind of gives us an estimation of maybe ovarian reserve. Radioactive iodine has been linked to a decrease in AMH levels, and that can happen, in the 3 months post. Kind of starts to get better gradually in a 1 year period of time. At 1 year period from the treatment, the AMH levels can improve, but they may not be quite back to baseline yet. And then we're still kind of getting more and more data for longer term assessment, but the studies that have been done that have looked for that 1 year period, yes, they do see AMH levels be affected. How much that affects fertility is hard to say, because it's kind of just a marker of fertility. And then what were the other parts of that question?
The early menopause.
Oh, yeah.
Yes.
Yes, it's been associated with earlier menopause, but it's not, it is considered to be more mild, right? So, like the patient was told, the doctor said about a year. So it's not usually like years early. It's relatively close, in the span of months to a year. Yeah.
And then part 3 of the question was about genetically mutates or the damaging eggs, but I think you covered that already.
Yeah.
Perfect. Perfect. All right. Anything to add, Dr. Desai?
No, I think she covered all of it. I was going to talk about menopause, but she covered all of it.
Perfect. 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 All right. Our next question is around RAI and its effect on DNA chromatin. Is there a test to verify it?
Not that we routinely use. I'm sure there may be a test in somebody might have a test in research studies, but not that we clinically use on a regular basis.
Okay, perfect. Our next question is around hypothyroidism from a full thyroidectomy, and the impact on fertility and getting pregnant, especially being dependent on thyroid hormones replacement medicine, basically. This person has met with a reproductive endocrinologist, but they did not know much about thyroid cancer and high TSH's infertility. Basically, should they be seeking out someone who is a specialist in thyroid cancer or an endocrinologist for reproductive support?
So, hypothyroidism itself definitely can affect your fertility, right, and your menstrual cycles if your levels are off. Most patients who have thyroid cancer are being treated with thyroid hormone replacement and then sometimes suppression, depending on the severity of your thyroid cancer. There's not a lot of data on kind of subclinical hyperthyroidism and fertility and its potential effects. We are kind of, interested in looking into that, but I don't think there's a lot of data right now that kind of can tell whether it really affects fertility or not. In the setting of pregnancy, subclinical hyperthyroidism is not felt to be an issue. So that's why when, we are suppressing patients for their thyroid cancer, it's been shown to be safe in pregnancy and for offspring and the outcomes. Fertility is just like a newer area that I think we don't have a lot of data yet to talk about specifically, but in general, we would recommend continuing your suppression if we felt like your thyroid cancer needed it, right? Because I don't think there's enough to say that we need to pull back on that and not suppress you so that you could undergo the fertility treatment options. Most physicians will proceed with the ART, even in the setting of a suppressed TSH. But the idea is to try to get it in the subclinical hyper versus like overtly hyper. That we want to avoid.
Perfect. And we had one more question that just came in that said, if you're planning to get pregnant, how long would you want a stable TSH, T3, or T4 labs before trying?
And in general, I think having like 2 labs that are stable would be ideal. So like if you were to meet with your physician and especially if it's been kind of rocky, if you've already shown stability for quite some time, then, you're probably okay. And with the most recent lab, you could proceed. But if it's still kind of like in flux, then I would say at least having 2 levels that are relatively stable 3 to 6 months prior to trying for pregnancy would be ideal.
That's what I would have said, is that, 2 to 3 months, just make sure you have 2. The bare minimum would be like 6 weeks apart to have, but I would say probably closer to 3 months.
Okay. One more question. Do you suggest increased ultrasounds of the baby during pregnancy if you don't have a thyroid?
No, I don't think we need,
No.
There isn't generally recommendations for that.
So the participant said that they were told that by their endocrinologist, they should be having growth scans every 4 weeks, but the OBGYN says it don't need it because of the 20 weeks, like you just said. So that was a little bit more context of the question. Any reason why someone would say every 4 weeks?
For the baby, right? We're not talking
Yes.
about, okay.
Yeah.
I mean, if the initial ultrasound showed something and you needed a follow-up ultrasound, the only other possible reason that I could think of is that antibodies, Graves antibodies, can cross the blood barrier to the baby. So if you had Graves disease, got a thyroidectomy, and found to have thyroid cancer, or your total thyroidectomy was from Graves disease, then yes, then we do sometimes recommend higher level of monitoring, but it's based on the antibody levels throughout the pregnancy. So if you have a higher level throughout your pregnancy, then we would recommend monitoring. If your antibody levels are very low or zero, we don't increase the monitoring. And Carolyn, did you have anything else to add?
No, that's the only time that I am interested in more frequency is in the setting of a Graves disease patient. Or patient with Graves disease.
Okay, perfect. Well, it looks like we have covered the majority of our questions. Some of them were very similar, and so we didn't answer every one of them, but we had over 21 questions. One just popped in here. Let's see. Does the increase or decrease of dosage of medication affect postpartum depression? And can it help with postpartum depression?
So for postpartum depression, if your thyroid levels are low, it's certainly not going to help. So definitely trying to keep the thyroid levels euthyroid is our goal. Now, in a person with thyroid cancer, the same thing, doing the TSH suppression would still be continued postpartum, and that has not been associated with any sort of worsening of postpartum depression at all. The thing to keep in mind, and this is in a group with thyroid cancer, so less likely an issue because most patients would have had their thyroid removed, right? So, but in the postpartum period, there are other conditions if you do have a thyroid still where you can get like a postpartum thyroiditis that can really cause altering levels of your thyroid hormone and has been, connected or associated with postpartum depression in some studies, very small studies. But that's something to keep in mind in somebody who still has a thyroid gland. If there's no thyroid gland, then the goal would be to try to keep the thyroid levels euthyroid or appropriately suppressed as you were prior to your pregnancy.
All right. And we have one more question that just came in. Do the postpartum meds interact with thyroid replacement hormone meds?
What postpartum medications particularly were they referring to? Most things actually don't interfere with thyroid medication. If there's a concern, you can actually get a repeat TSH in 6 to 8 weeks after starting a medication if you're very concerned about it. The main medications that we look at are amiodarone, lithium, calcium, which can change the absorption, and some heartburn medication, which changes the acidity in the stomach. Those are known to change the thyroid levels. Everything else, if you separate it from your thyroid hormone, should not have a significant impact on your TSH levels. But again, if there's concern, you can take the medicine. We always recommend taking the other medicine, and then we'll adjust your thyroid hormone afterwards. We don't recommend not taking the other medicine if it's medically necessary.
One med to add is just iron. So maybe if someone got started on iron postpartum, that you can still take it, but like Dr. Desai said, separating it by a minimum of 4 hours is recommended so that it doesn't interfere with the absorption of the thyroid hormone.
Perfect. And they did follow up and say that they had some issues with alternate medications because their thyroid meds were too high for a few years. So that was the context of the question before. Well, we are at 3:20 and we have answered a lot of questions, 24 questions to be exact. And if there's any other questions, feel free to drop them in the Q&A. If there are no other questions, we want to say thank you to Drs. Nguyen and Desai. This has been a very informative session, one that I am also personally interested in. So I was very happy to host this and hear from two women who are rocking it out in the medical field. So we're just so grateful that you're all here. And thank you also to everyone who attended today. And feel free to reach out with any questions. Dr. Nguyen and Desai's contact information is on the ThyCa website as well. So if there are no other questions, we want to say thank you all so much and have a great conference.
Thank you.
Thank you.